My name is Hans Buitendijk. I am a Senior Director of Interoperability Strategy at Oracle Health. Today here I'm on behalf of the EHRA, EHR Association, a group of EHR vendors, where I'm a part of the executive committee, have been the chair of the overall association, have been the chair of standards and interoperability, which I think we're going to talk a little bit more about, and then currently a chair of the public health workgroup that we have within the EHRA. So that's a little bit of my background within that, and have been active. I'm continue to be active as a member of the HITECH within the US, appointed by in that group, 807. Various networks like Commonwealth, Care Quality, TEFCA, etc. So whatever is interoperability, you might have a shot to see me there.
Yeah, excellent. All things interoperability. And so I'm keen to learn a little bit more about, I guess, some of the key topics or the themes that are important to, the EHRA at the moment. We were discussing a few kind of hot topics just before we recorded. Tell me about what's top of mind at the moment for you in the space.
Top of mind, a couple of things. There is the rule that came out by CMS, interoperability and prior authorization. There is the rule from ONC around HTI1, advancing the ability to interact. So interoperability in that regard is one of the key topics around that is top of mind for EHRA. Right now, prior authorization is one of them. TEFCA is starting to play for many members a role. But then we also have states that are, while we have federal regulations, we also have states that are having different initiatives. And we also see them have their implementations, which are not always the same. Are actually, better to say, they're typically different.
Right.
So that's top of mind on how we can best do that as consistent as possible. Yes, one of the key for us. Consistency. We can talk with everybody the same way, as opposed to many different ways.
Well, I guess that's the core of standardisation and everything would be that consistency piece. So from the top there, to understand, tell me a little bit more about TEFCA, not something I'm totally across from the other side of the world. Why is that top of mind for you?
It's top of mind because it is it's a next step into how we can achieve national level interoperability in the United States. So we have had over the years, over some of the decades, connectivity at a regional, local level, then state level. We have national networks like Care Quality, Commonwealth, eHealth Exchange, etc. That started to make it easier to share data across the United States among everybody. But now TEFCA is taking the next step, driven by 21st Century Cures Act, to improve upon that, to advance that further, more use cases, starting to move into fire-based exchange, etc., and doing so with different parties as well. Typically, so far has been providers, but how can we get public health in place? How can we get the payers into the mix as well? Other areas and stakeholders. So it's much more about broadening it, expanding it, getting into new technology. So in that sense, that's where many of our members will support our clients, our providers, to enable them to do that.
Yes.
So that's why it's top of mind on how do we make sure that all works.
And then I guess extending that to understand a little bit more, when you said from the state and federal kind of nuances and the challenges there, that resonates for me from the Australian point of view. But it's interesting that you say it from that. So that's nuances that providers need to be aware of. Tell me a little more about these state and federal.
A couple of examples that I will use along the way is that at the federal level, for example, we have certification requirements to help systems to be more consistent around how to report to public health. But then public health agencies have different requirements of more or less data, different criteria when to report or not. So you have very natural differences because the jurisdictions have different requirements on what they need. It's not just the CDC needs data and that's now what everyone collects. It is every jurisdiction has the opportunity and actually the responsibility to identify what's important to their state. That's part of the U.S. federal system on how that works.
Yeah.
So very understandable, but that creates variations there. Has been for many years. But at this point in time, on the more current changes, federal level requirements through ONC are around U.S. core data set for interoperability. That's across the country. That's a certain version. But states might say, I want you to support a more current version. Right. Than what the ONC required. Or we now get into privacy considerations, data segmentation, is that depending on state law and rules, certain data may or may not be exchangeable across as the jurisdictional boundaries. So the individual provider, if they only operate in their own little geographic area, then at that point in time, we can say, okay, it doesn't matter that much. I just need to worry about my own. Yeah. As vendors, we support clients across different states, so we have to worry about it. But providers have to be considerate about it. Well, because their patient might cross jurisdictional boundaries.
Yeah.
Where is the data coming from? Who am I sharing it with? Can I not, based on the variations in privacy rules?
As you're saying that, I'm thinking, well, who's this the biggest problem for? Is it the not a problem, or I guess who needs to be most across it? Because from a you've got the vendor side, and then you've got the provider side, and the burden and responsibility, or if things go bad, it's going to fall back on someone. But it sounds like a bit of a collaborative approach. All the different stakeholders need to be across all of these particular issues.
Yeah, and it depends. It's that so. There are considerations and concerns for providers, because what are for them some of the legal implications of where they share or not. Because you have, can I share it? Yes or no. But if I don't share it, do I have an information blocking issue in my hand? So you have that.
You can't even do it.
Conundrum from a provider. So that needs to be more clear. That creates ambiguity. From a vendor perspective, is that how do we manage this? It might be that where are some of the penalties? Do states have penalties for this? On who? Is it on a provider or is it on the vendor? One or the other, or both.
Yeah.
So, and that can vary. So there are places where there are, depending on what happens, is that after we have to support it, we might be subject to certain penalties as HIT providers.
Yeah.
In other areas, it might be the provider, or it might be both. So that's where you are looking at. It's a complex fabric on figuring that out. So state variations can create some challenges, substantial challenges. And on the other side, they are very understandable that there need to be variations. Some areas we would like to be more consistent, but it's understandable. But how do we manage that? How do we support that across the board?
Yeah.
That's hard.
Yeah. It sounds like, and you want to build with those requirements in mind, but also have that flexibility to be able to continue to evolve with changes and the times too. You don't want to be restructuring everything from the ground up every time. What was the third?
Prior authorization.
Yes, tell me a little bit more about that.
Prior authorization is a major workflow that in the U.S. on how to ask for authorization from the payer that a certain procedure, service, test, whatever, will actually be paid for. Because if not, then the patient would have to, or their guarantor would have to come up with more a contribution to that.
Yeah.
And is that appropriate? So it is the entire interaction between provider and payer to say, I would like to do this as a provider. Payer coming back and says yes or no, or hey, you need to give me these 10 attributes, these elements to say that based on that, I can determine where I can do it. So that interaction is a workflow between provider and payer. And that's very complicated quickly. On the outset, you would say, it's very straightforward. But typically, both on the provider and the payer side, we have multiple HITs in place. It's not just a singular EHR. I might have a scheduling system. I might have the billing system that is not the same. In other areas, it is the same, but it's not always. And frequently, it's not depending on what organizations should look at. So the complexity is now, it's not a simple query into one system and I'm done. I need to coordinate. I start in scheduling. I initiate it. I need to get information from the EHR, the clinical data, to figure out, can I do it? They might find out that, I did not get all the information.
Yeah.
I need more. I need to ask, how do I manage that manually now? How do I now notify the ordering provider and the billing system to say, hey, you can go ahead, and the billing system, this is your authorization you need to include in your play. So that kind of is a workflow that is not just a simple query, one system, and that's it. Multiple systems possibly, likely. So that's the complexity, that's the top of mind to understand. CMS put out a rule to indicate payers, you need to support your end of this. It indicated to providers, if you don't start to do something when this goes into effect, then you do not get contribution towards your performance. That may have a financial impact. And we're now waiting for ONC to see where the next rule, HCI 2, what is their aspect to it to help manage that. So that's a top of mind, because it's we want to make sure that providers can step into this, but we also need to recognize that we still have a lot to learn on how to best manage that across multiple systems in one singular workflow.
Yeah.
That's That's the trick.
Yeah, that's important. And I guess if at stake is there's financial implications from a provider point of view, it certainly gets attention, so important to get it right.
Absolutely.
Lastly, then, we're at HIMSS, and there's a lot of these, issues front of mind that you've just described. What excites you about this future of the space, and what are the future projects that you can speak about?
Yeah, what is exciting about being at HIMSS is that over the years, the EHRA, its members are typically present here at HIMSS in a variety of different places, but also the variety of stakeholders, federal agencies, ONC, CMS, others are all present here as well. So it's a great place to have in-person discussions and better understand where are we heading, or raise some of the questions, get some clarity around that. So I just came out of one of the meetings there where we talked with ONC, CMS a little bit more about these are some of the questions that we have, these are some of the concerns, and having that dialogue, and then having that as well with provider organizations, and having that with other parties. It's a fantastic place that we can learn from each other, that we can interact with each other, and that we figure out a path forward. This is not a individual sport. This is a team sport. It is a team to make this all happen. So it's a great place to meet and learn.
Yeah, amazing. And any other projects or final thoughts to close it out? Things that you're excited about?
Anything else is that we have many more topics. We talk about usability. We talk about public health. We talk about patient safety with the members and how we can advance that. So there's a number of other topics now also with artificial intelligence. What is the role of that? So you see within the organization an interest to can we learn together? And some people might surprise them that we have all these competing vendors, but they're coming together.
Yeah.
But we're really coming together because a lot of these issues cut across our members. A member of a organization has clients that another member has clients as well. So we constantly have to work together. So how can we advance everything for our clients together? We will compete, but on a number of issues is that absolutely we have to work together or it will work. Interoperability is a key one where if you don't work together, it won't work.